Good evening, everyone, and you're welcome to our Abu Dhabi STEMI Task Force Symposium. This symposium, of course, a lot of people knows about it, and we have been conducting it for the last a few years, every quarter. And this is the first time we conducted as a webinar. The last few years we've been conducting it physically, where we invite people. The number of people most of the time have been limited to between 50 to 100 attendees. So, and the purpose of that usually was to keep it a very interactive webinar. We conducted over a duration of something between 3 to 5 hours, with a lot of cases and a lot of ECGs, and also with the sharing of our experience in Abu Dhabi in terms of management of ST elevation myocardial infarction. I would like to thank a lot of people who have been part of this symposia, and especially Dr. Sharif Bakir, Abu Dhabi police representatives, ambulance services, emergency departments, my colleagues at SKMC and SSMC, Dr. Nadia, Dr. Yara, Dr. Yusuf, Dirar, and Mohammed, and Andre, Jane. So a lot of people have been part of this symposium, and there was a lot of learning and a lot of positive feedback. This is our first experience, of course, as a webinar, so we don't know how is it going to look like, because we are used to it as a very interactive, symposia. So moving forward with the symposia, because the time is short, we'll try to limit the time to an hour and a half, so we don't get you bored, and also try to give it a try and then adjust as we move forward with with this experience. Of course, we welcome your feedback after this meeting, either through messaging or through the platform from the organizing company, or directly to me. There's a few things that before I start, I would like to to share with you. So please don't forget to press the unmute button once you join the webinar. Don't forget also to of course, to claim your CME. I'm going to show you the slide that, or the icons that you have to press. Of course, if you want to chat or you have questions that you want us to address, please, on your screen, you will find what you've seen here on my screen, chat as a guest. Just press on it and type your question. The certificate, you can claim it. I think the button is very clear in front of you on your screen, and I think the button gets activated at the end of the presentation. There's another part, as I say, the interactive part of this symposium. We try to, as much as possible, to make it interactive. So we got some questions throughout the symposia that you will see throughout our presentations. Please be engaged in participating and trying to answer the right question. That indicates that you're listening and you're engaged into the presentation and into the discussion. I think we'll go ahead to the next presentation. So we'll go for a break for a few seconds and then come back. So my first talk is going to be just a few slides, just to tell you, or to pass the message, how important it is to manage STEMI patients, and to manage it as a system care rather than an individual provider care. So first, before we start, we all know, and I think I'm just trying to emphasize on this again and again, is primary PCI as a reperfusion strategy. So if you have an occluded, so STEMI, it means that you have an occluded coronary artery, an occluded major coronary artery. And to open that artery, you have two methods, which is a mechanical, opening it with PCI, or by pharmacological, which is thrombolysis. A lot of trials address this question as to what is better, primary PCI or opening the artery with the PCI, or opening it with pharmacologically. And basically, this is well-established evidence. The guidelines already recommends it as the first option for reperfusion, of course, in the right setup, with the right experience, and in a timely fashion. This is a meta-analysis that looked at 23 randomized controlled trial with thousands of patients, and you can look at the death, which is in red, and look at thrombolytic versus blue, which is a PCI. So clear cut with the very significant p-value. So very clear cut evidence of superiority of primary PCI. Another point that talks about the downside of thrombolysis, and I have a case, I don't know if it's, I'm going to show you, which is a intracranial bleed, where a patient gets thrombolytic and gets complication of intracranial bleed. Those patients, usually mortality is extremely high. So if a patient gets a complication of intracranial bleeding, the chance of death is extremely high. Now, if you give also thrombolytic therapy, the patency rate, the opening of the artery, is only 55%. So with RTPA, the thrombolysis that is given for STEMI, 55% of the patients will have their artery open, while with the primary PCI, usually more than 90% of the patients, they will have their artery open. Also, the incidence of coming back with ischemia and reinfarction is very high compared to primary PCI, very high with the thrombolytic therapy compared to PCI. So I think the evidence is very strong and well established when it comes to primary PCI versus thrombolytic therapy, and I don't think it should be a time to argue against that. I think the key is how can we ensure that the care is delivered to all patients within our societies, within our communities. So in the community of Abu Dhabi, which is, I'm going to show you on the map, we worked hard with our colleagues, either in the private sector, in the primary healthcare, in the small hospitals, the non-PCI hospitals, and also in the PCI hospitals, to create some sort of an integrated system where, regardless of the patient where he presents to, he will get a care, or he will have his artery opened within a timely fashion, where he can get the benefit of this evidence and this care. So if you look at a society or community like Abu Dhabi, this is the number of clinics and hospitals that there. We have 56 hospitals, a lot of thousands of beds, 1,321 centers and clinics. And remember that a patient with a chest pain or with an acute MI can present to any of these centers, either in the land here or in the sea and the Gulf. And the key is how to create a system. If this patient presents to any of these centers across, he will be transferred and triaged in a timely fashion. He will be first recognized before triaging, recognized, identified, and diagnosed, and then triaged to a PCI center where he gets his artery opened within 120 minutes as recommended by the guidelines. So that is the key as to how can we function and work as a system. And that's why we invite people to such an activity, to work together, to educate each other, and to learn from the experience of each other as to what are the gaps and how can we solve it and how can we get better. So we looked at our community. So 63% of the population lives in this region, and there's a multiple cath labs if you look at this region. If you know that, if you're familiar with this, for those people who comes from Abu Dhabi who listens to us, most of this area, most of the population lives within this area. And there is a multiple hospitals that got cath lab and can provide a 24/7. The same thing here, about another 23% of the population lives here. And the same thing, there's a multiple PCI centers. Of course, this is the remote area with, 200-300 kilometers away. And, but also, luckily, these remote areas, only 10% of the population lives there. But as a system, I think we can, and we already proved that, any patient who presents to any of these centers or clinics can be transferred within a timely fashion to a place where he gets the care. Of course, in Abu Dhabi, we estimate about 1,500 or 1,500 to 2,000 STEMIs every year. Of course, the number, some people may think this is not so many. But of course, if you know the mortality, the chance of death from acute MI, if you don't recognize and you don't treat, is more than, it can get up to 50%. Of course, a lot of these patients, they don't get to the hospital. They don't get to to see a healthcare professional, either it's EMS or emergency. But those who gets to our hands, if we don't diagnose them because they get misdiagnosis or they don't get triaged properly, their mortality is extremely high. So our role is to identify and treat them in a timely fashion. So what are the barriers to get this done? Of course, you need an integrated healthcare system, and already there's a lot of work. And as you saw on the previous slide, almost now 90% of our population are getting a primary PCI. And this is based on the data from the Department of Health, from the coding data or the claim data. Of course, some people may question that data, but if there's a margin of error, we can say with confidence at least 80+% of the STEMI patients in Abu Dhabi are treated with a primary PCI, which is I would consider one of the best internationally as a penetration of primary PCI within this population of STEMIs. The gap we're trying to fill is by working together, by creating a more integrated healthcare system, more collaboration between the public, the private, between the primary care and the secondary and the tertiary care. The transfer policies across facilities, we have challenges, of course. A lot of you who knows when it comes to transferring a patient from a facility to facility, if there's no proper agreements between facilities, usually transfer becomes difficult. So pre-arranged agreements for transferring patients with a STEMI should be done, and that should not be the time to discuss a transfer when you diagnose acute MI or when the patient is in front of you. This should be done as very clear written before you get to see a patient's. Competition among healthcare providers, of course, sometimes can put the patients at risk. Some healthcare facilities would rather keep the patient and give him a thrombolytic so they can keep their population or their patients within their hospitals or within their systems. I don't think this is appropriate. If someone is going to thrombolize a patient, he should not, and I think he should sign an agreement and transfer him to a place where he can get a better care. Of course, some of the providers thinks that they don't have the full authority, so they can address the full picture because they say, "Oh, I don't have an authority to correct things." Actually, you can correct if you work together. Some of our patients, they may have financial challenges. We're lucky here in the country that all these patients, if they come to a certain hospitals, they can be waived and covered because this is a life-threatening, and it's very clear by the mandate and by the government that life-threatening conditions are covered completely without any risk of payment. Of course, we need to work on variation on standards we need to ensure that patients receives a equal standard of care across the board, across different providers and different whatever he presents to, either a primary care or a secondary, a private or a public sector. So those are the challenges, and I think we need to do a lot of work on them. Of course, creating a registry is another big one that we need to have some work. So without more delay, I'm just going to move and give Dr. Bakir, the chance to talk. Of course, for those who doesn't know, Dr. Bakir is a cardiologist who practicing in Abu Dhabi for many years, and his role usually is, educating us about, it's not as directly as STEMI cases, but it's about the prevention. And all of these patients, I can tell you, they go back to the community, they see primary care, they see general medicine, and they see other cardiologists. And usually we are poor when it comes to preventing another acute STEMIs or another STEMIs. And I think it's very important. Part of the STEMI care is preventing or secondary prevention and preventing this happening again. So I would start with that, and then I would move to and share with you some of the cases. Dr. Sharif is going to give you, I think, something like a 20 minutes presentation where he shares with you what is the optimal treatment if these cases comes to you. So we're starting with the prevention, and then we'll go to the real cases. I'm done here, and we'll get you to Dr. Sharif.
Dear colleague, it's great pleasure and honor for me to be with you today. I think after the presentation or the introduction by Dr. Zubeidi, somebody will ask, we are here today to talk about STEMI. So why we are talking about primary and secondary prevention? Just to understand this, I will go with you to some challenging cases about the usual what we are seeing in our practice, which is hypertension and dyslipidemia. And the aim is just to tell you why we are doing this. Let us to start by this one. I will talk about one case, which is Mr. Mahmoud. He's a 56 years old male. Mr. Mahmoud is a smoker, obese, dyslipidemia, not diabetic. Where his father died by developed an MI at the age of 45. No past history of any medical history and no treatment. Mr. Mahmoud blood pressure is 147 over 82. So the question is why we want to do primary prevention for, or second, now we'll consider it primary because Mr. Mahmoud does not develop any heart attack. So according to the new guideline 2019, American College of Cardiology, American Heart Association on the primary cardiovascular prevention, we have to understand why we are doing this. To understand this, first of all, I want to tell you in continuation of what Dr. Zubeidi was telling, 80%, and I want you to remember this number, 60 to 80% of the people who develop acute MI, they never complain before, which means the first presentation for them in the emergency department will be heart attack or sudden death. 80%, 60 to 80%. If any of you are working in an emergency department or in AHS and saw someone with acute MI, you will discover that most of them, they never complain. The second thing is, this is a normal coronary artery. If we look to this normal coronary artery, we'll find that after 1 minute, this coronary artery can develop like this, totally occlusion. I will return back the picture to see this is a normal coronary artery. And if you look here, there is minor narrowing, but then suddenly he can develop this. The question is why? If you still remember the histology and you look to the histology of this coronary artery, you will find this is a normal coronary artery. There is no narrowing, but in spite of that, this coronary artery have been blocked by a big thrombus. The question is why? Why normal? There is no narrowing. If you look here, there is no narrowing. Why this LAD artery developed big thrombus in spite that there was no narrowing before? To understand this, I want you to look to this slide. This is a normal right coronary, but if you do intravascular ultrasound to this normal right coronary, we'll find that the wall of the coronary is full of plaque. All this yellow is a plaque. So the question is, who have this plaque? The answer is you, everybody, all of us. We have this plaque inside of our coronary artery. If we do intravascular ultrasound to our coronary artery, and if we are about, for example, the age of 50, 100% of the people whose age of 50 will have this type of plaque inside the coronary artery. The question is, why some people develop heart attack and the other does not develop heart attack if all of us, we have coronary plaques in our coronary artery? I will go back with you to the Interheart study, which has been published first time in Munich, European Society of Cardiology in Munich 2004. They have done a very intelligent study by Dr. Salim El-Yusuf. What they said, anybody develop heart attack, I will take same nationality, same age, same sex, from same place without heart attack. This study has been done in 52 countries. And they take 16,000 with heart attack and 16,000 without heart attack. And for example, if American living in Abu Dhabi, his age is 50, develop heart attack, I will take American living in Abu Dhabi with age of 50 without heart attack. Whatever, any Egyptian, any nationality in any place, develop heart attack, I will take the same nationality, same age, whatever the place is, without heart attack. And we find that we have 9 risk factors. Today we'll concentrate on only 2 risk factors of this. We'll concentrate on the dyslipidemia and the hypertension. And I will show you why. To understand all the risk factors are affecting our endothelial cell. This is a 40,000 magnification of cross-section of our arteries. And this is the endothelial cell layer, which is a single cell layer lining of our vessel. And this is where the risk factor will do its effect. So, somebody will develop heart attack because of risk factor, hypertension, dyslipidemia, diabetes, smoking, obesity. All of this will lead to endothelial dysfunction through which the plaque will develop, and then suddenly the plaque will rupture. And once the plaque rupture, it will lead to atherosclerosis and thrombus and the coronary occlusion. The same way that I show you in the first slide with the normal coronary, and then suddenly develop a thrombus inside. When we are talking about a primary or secondary prevention, we have to know that the risk. We are not treating numbers. We are treating human beings. What does it mean? Which means that the same person, if the risk factor have been changed, that the possibility of developing heart attack will change. For example, look to this one. This is a male, 50 years of age, systolic blood pressure 120, diastolic blood pressure 70. His height is 54 by inch, and his weight is 100 pounds, and his body mass index, for example, is 29. He's smoker, and the patient is risk factor will be 8% in 4 years, 4% in 2 years, 2% in 1 year. If we increase the age of this person, we'll make it 55. With the same number, we'll find that his risk factor have been changed. It became now 19% in 4 years. If we increase the blood pressure with the same parameter which we are giving, we'll find that same age, but blood pressure became 147. We'll find that his risk factor over 4 years, it's jumped to 73% to develop heart attack. This is to explain for you what we mean by the accumulation of the risk factor. If we go to the guidelines 2017 for the American ACC guideline, American Heart Association, we'll find that the blood pressure parameter have been changed dramatically. They say that the normal blood pressure is below 120, elevated blood pressure from 120 to 129, stage 1 hypertension 130 to 139, and the stage 2 is 140. If we look to this, we'll find that all of us will be hypertensive and all of us need to be treated. But actually, this is not the case, because according to the guideline, you're not looking to the number. You have to calculate the risk factor on top. And this is why the guideline, European guideline 2018, which 1 year after the American came, and telling us, no, we are not doing the same. We are looking for what is called optimal hypertension, normal, high normal, which was hypertensive in the American, grade 1 hypertension, grade 2, grade 3. For the first look, you will tell me that these two risk factors these two guidelines are completely different, but actually they are not different. They are exactly the same. And this is what I will try to show you in the next few slides to understand what we should do to prevent the heart attack by preventing the risk factor. I want you to understand also that risk factor, for example, like hypertension and dyslipidemia, will affect our brain, heart, and kidney. But usually we have something called the subclinical stage. What is the subclinical stage? Which means that the individual will have this risk factor, but without any manifestation. And suddenly he will develop what is called the plaque rupture and the clinical disease. So our aim as a physician, we have to catch these people during the vulnerable, the subclinical stage, before the risk factor lead to sudden death. Also, another important point we have to understand, if you look at the cross-section of our coronary artery, we'll find that the fatty deposition on the plaque will occur eccentric in the beginning. Yani, for example, this is normal vessel, and this is minimal coronary artery disease, moderate coronary artery disease, but look to the lumen of the artery is still patent, and then suddenly it will rupture. So in general, if you want to prevent heart attack, you have to know that it is depend on the number of the risk factor and the lifetime where the patient or the individual exposed to this risk factor. So the more the lifetime, the more the number of the risk factor, the more the lifetime, the more the morbidity and the mortality will be there. Let us to return back again to Mr. Mahmoud. So my question is, Mr. Mahmoud blood pressure is 147/82. So the question will be, does he have hypertension? I will give you 1 minute to think. So the answer will be yes or no. If you decided to say yes, this patient have hypertension, or you decided to say no. Let us to see the guideline. What is the guideline telling us? We'll see that according to the guidelines, he's grade 1 hypertension. This is European. And according to American, is the same. But let us to see the European Society Guideline 2013. Diagnosis of hypertension, this is 2013, depend on office blood pressure, is recommended for screening and diagnosis of hypertension. But we discovered this is not true. The guideline came in 2018, say no. It is diagnosis, it is recommended to base the diagnosis of hypertension on repeated office blood pressure or out of office blood pressure measurement or ambulatory 24-hour blood pressure monitor. So this is a great change. This means that when we diagnose the presence of hypertension, we are not depending on one reading. We have to do office reading plus out of office reading plus ambulatory if available. This is the most important thing. If we find that Mr. Mahmoud, after a repetitive measuring of the blood pressure is still high, so we'll consider Mr. Mahmoud now as a grade 1 hypertension. Now we have to look to this. Grade 1 hypertension, should I start medical treatment immediately or there is something? Let us to go to the European Society Cardiology Guideline 2018. They're telling us, grade 1 hypertension, first I have to do lifestyle advice. Immediate drug treatment will be only for high-risk patients. So we are still the same like the American. So European and the American, they're telling us the same. Don't look to the number alone. You have to look how much risk factor. For example, coronary vascular disease, kidney disease. If the patient does not have any of this risk factor, so I will give him 3 to 6 months of lifestyle intervention, and then I will repeat the blood pressure again. So this is to understand the immediate and the importance of calculating the risk factor. So let us to go back to the European Society 2013. They said, now, if the blood pressure below 140, don't do anything. And then the 2015, there is a big trial called, the big trial came for the hypertension, which is a randomized trial to tell us, which called the SPRINT trial, to tell us better to have higher lower than 120, or you can keep with 140. And then the 2015, it's been published telling us, no, it have been better now to reduce the blood pressure. This is in contradicting to what was in 2013 guideline. Then the American guideline 2016 came, and the European came after that. But I want you to look. Both of the guidelines, both of them, they said, yes, I want the blood pressure to be below 130 in the European and below 130 in the American, but depending on the risk factor. How many risk factors Mr. Mahmoud have? Also, we have to understand when we treat blood pressure, we have to know that not all the patients are the same. Some patients, maybe I will need to use more for renin-angiotensin system. Other patient, I will use more sympathetic nervous system blocking. Other, I will use to reduce the sodium. So not everybody or each individual are the same. Why I am telling you this? Because our aim at the end of the day, we want to prevent heart attack. Because we have to know that hypertensive is a silent disease. And we know that blood pressure is the cardiac output times the peripheral resistance. So, and the cardiac output is the heart rate and the stroke volume. And the peripheral resistance is arterial and venous. And we'll find a group of the medication, all of them can affect this. So now let us return back to Mr. Mahmoud. According to the guideline, what we'll do with Mr. Mahmoud, according to guideline 2013, they said initiation of drug treatment, initiation of antihypertensive therapy with a 2-drug combination may be considered. While in 2018 now they said you can start immediately from the start with combination to make more compliance and more control of the blood pressure. So the answer is, does Mr. Mahmoud have blood pressure, high blood pressure? Yes. Now we'll go to other things. Mr. Mahmoud, his lipid was 136 milligram per deciliter. The question will be, does he have dyslipidemia? Does Mr. Mahmoud have dyslipidemia? The LDL is 136. Should I treat dyslipidemia or not? Now we'll go again. Yeah, A, yes, B, no. Just for less than 1 minute, I want you to calculate in your mind. Now we know that Mr. Mahmoud have high blood pressure. The question is, his LDL is 136. Should I start with statin with Mr. Mahmoud? To answer this, let us to see the new guideline 2019 in the European Society of Cardiology meeting in Paris. What they say? The same. We are not treating number. We are treating human being. For example, if Mr. Mahmoud is diabetic, less than 10 years, I want his LDL to be 116. If Mr. Mahmoud is diabetic more than 25 years, I want his LDL to be 100. If Mr. Mahmoud have heart attack before, I want his LDL to be below 170. If Mr. Mahmoud is having high developed heart attack and also chronic kidney disease with diabetes, I want Mr. Mahmoud LDL to be 55. So we are not treating number, we are treating the risk factor. Let us return back to Mr. Mahmoud. Smoker, obese, dyslipidemic, but not diabetic. So I can keep his systolic blood pressure around 130, but Mr. Mahmoud is hypertensive. So now I need to reduce the LDL below 130. So the question would be, yes, Mr. Mahmoud need to be on a statin treatment. So we decided to start with Mr. Mahmoud dual combination of calcium channel blocker plus renin-angiotensin system. But the problem, because Mr. Mahmoud does not complain of anything, he did not take the medication. So he does not take his treatment. Why? Because he feels nothing. And we didn't explain to him clearly why we are giving. We want to prevent Mr. Mahmoud from developing heart attack. This is the meaning of primary prevention. So Mr. Mahmoud is smoker, obese, and all the time we said drug does not work in patient who does not take them. And this is exactly what happened to Mr. Mahmoud. So 2 years later, when Mr. Mahmoud became 50 years of age, he developed non-ST elevation, MI, and the stenting have been done to the right coronary artery to prevent reduction of the ejection fraction. So what happened? We start with Mr. Mahmoud now, S inhibitor, ARB plus beta blocker. Why we start the beta blocker? Because Mr. Mahmoud now became a heart attack. He developed acute myocardial infarction. And according to the guideline, we start hypertension and coronary artery disease. We start usually by ACE inhibitor, ARB, and beta blocker. If not responding, we have to go to step 2, 3 triple vessel. If not responding, we have to go to add spironolactone to Mr. Mahmoud. And now we know that LDL and risk of cardiovascular disease and systolic blood pressure and risk of cardiovascular disease will find that if the presence of the combination, which means that LDL plus high blood pressure, the morbidity and the risk for developing heart attack will be much more. So Mr. Mahmoud, after that, he's done smoking cessation, start exercise, lose weight in 4 years. And he came to us after 4 years, which is now Mr. Mahmoud known to be reduced weight, dyslipidemic, no diabetes, coronary artery disease 4 years back, and he's taking low dose of aspirin, statin, and antihypertensive. Now his blood pressure is 135/82, and LDL is 97%. Let us to ask the question again. Does he have high blood pressure now? The blood pressure is 135. The question is Mr. Mahmoud hypertensive now, which means that blood pressure is not well controlled or not? And should we start pharmacological treatment for him or not? A, yes. B, no. I want you to just half a minute, try to decide. Should I add more for the treatment for Mr. Mahmoud, or his blood pressure for me is okay, 135? Let us to go to the guideline. The guideline, what is the guideline telling us? Mr. Mahmoud now on treatment, but his blood pressure is more than 135. Both of them, the American and the European. So for us, Mr. Mahmoud is not well controlled because his blood pressure is more than 135. Why we calculate this? Because based on the risk factor calculation. Now we'll go one further step. According to both the American and the European, he should be treated. Now Mr. Mahmoud blood pressure dropped to 132. Still for me is not well controlled. Should pharmacological treatment to be initiated now? Yes, to add more, because I want his blood pressure to be less than 130. And we'll find that what is the treatment target for Mr. Mahmoud? The treatment target upper threshold or lower threshold? I want Mr. Mahmoud to be less than 130, but not less than 120. Why? Because Mr. Mahmoud age group is 18 to 64. I don't want to reduce the blood pressure below 120, but I don't want to keep it more than 130. In the same time, for the diastole, I don't want to be reduced below 150. But sometimes in the diastole, we cannot control it. So sometimes you have to depend on the systole blood pressure. I want Mr. Mahmoud to be below 130, but not below 120. Now we'll go to which blood treatment. This presentation, I gave it in Washington on AC, in American College of Cardiology meeting. And my talk was that time, 2017, polypharmacy and the compliance. We'll find that the combination of the drug combination in one tablet, it's much, much better than the giving separate pills. Now we'll go to the guideline. What is the cardiovascular risk said? To summarize, I am saying that I want to control blood pressure. Why? Not because of the blood pressure is symptomatic disease. Because Mr. Mahmoud, if we didn't control his blood pressure, because of the presence of risk factor, he will develop the heart attack. The cardiovascular risk is influenced by severity of hypertension, other risk factor, and mediated by organ damage. Does Mr. Mahmoud have dyslipidemia? Now his LDL 97. So I want you to think again. His LDL 97. So the question is, should I increase his dyslipidemic treatment? Yes or no? Let us to see the guideline. What is the guideline? If you go to the guideline, we'll find now Mr. Mahmoud developed heart attack. So his LDL now is more than 70. I want his LDL to be less than 70. So this means that in spite that the LDL of Mr. Mahmoud have been improved before compared to what he have, but still above the target level. Now, Mr. Mahmoud came to us after 10 years. Now he is 72 years of age. His blood pressure is 145/66, and his LDL also will be elevated. The question is, should treatment be modified? Should I reduce the blood pressure below 145? Why we raise this question? Because there was a debate in the American College of Cardiology meeting, in the American ACC guideline hypertension. Some people said anybody over 60, I can accommodate or accept systolic blood pressure of 150. But this have been changed in the recent guideline. They said, no, Mr. Mahmoud should control his blood pressure and also look to the LDL 82. Could I accept this 82? Let us to see the guideline. What is the guideline telling us? Now, Mr. Mahmoud is between 60, we said if between 65 to 97 to 79, still my target blood pressure should be 130 to 139, which means 145 is very high for Mr. Mahmoud. Now, we have to understand that when we put the guidelines plus the risk factor plus the number, we are able to give the proper treatment. His LDL is 82, but is still above the target because the target is 70. So don't forget that even minor change, minor millimeter mercury in blood pressure or millimole in lipid is still above the needed. So to summarize what I will try to say, recommendation treatment goal for the LDL, 2016 they said we want to below 70, 2019 now they said we want to below 55 for high risk patient. For very high risk patient. For high risk, I want below 100 in 2016, while in 2019 I want to below 70. And moderate risk, I want to below 115 milligram per deciliter in 2016, while I wanted below 100 milligram in 2019. And low risk, I want it to be below 115. So from where we get this? From many data and many studies. So what is the take-home message? That I want to be in my mind the disease plus the risk. It is not the disease alone. It is not the risk alone. We have to put all together to fulfill the criteria of the guideline. So our aim is to die young as late as we can, and we want to do some form of investment in our artery to prevent the sudden onset of heart attack, and this is what we call primary and secondary prevention. I will stop here, and I think now we want to do some plastic surgery for our patient. We want to be this like this and this like this by doing what we are doing. Thank you very much.
Great. Thanks, Dr. Bakir, for this very informative and summary of prevention. Now, I got a couple of questions that I'll ask you that I received from the audience. I received, multiple questions, but because of the time, I had a question about aspirin in primary prevention. I know there's a lot of evidence.
Very good, excellent question. According to the new guideline,
1 minute aspirin in primary prevention.
Okay. In the primary prevention, the aspirin have been stepped down. What does it mean? For example, now they keep the aspirin for very high risk patient primary prevention. Why? Aspirin, if anybody take aspirin, there is a 6% per year to develop hemorrhage. And this hemorrhage could be fatal hemorrhage. They can develop cerebral hemorrhage, renal hemorrhage, whatever. So we have to calculate the risk of the patient. If the patient risk factor is more than 6% by using the risk calculator in the presence of dyslipidemia, diabetes, obese, smoker, so this is high risk patient. Here, there is some place for the aspirin. Why? But if the patient is moderate risk or mild to moderate, there is no place for the aspirin because of the risk of bleeding. So aspirin is not a safe drug like what we used before. So this is where we return back to the same, which is the risk calculation. You have to calculate the risk of your patient.
So risk of bleeding and risk of events, and based on that,
you decide.
Another question is related to the lipid lowering in the setting of acute MI. Do you go aggressive from that time, say statin and PCSK and ezetimibe? Where do you start for acute MI?
So according to all the guidelines, when the patient develop, we have to differentiate between somebody who's statin naive, that he was not on any lipid lowering before the heart attack, or somebody who was in lipid lowering and then he developed the heart attack. This is first things. Number two, we have to know that the statin is a very good drug. It's the drug number one. The first line treatment is a statin. But the problem is some people cannot tolerate statin. Why? Because of the muscle pain. What is the actual story of the muscle pain? It has been varied from 5% to 20% to up to 30%. We don't know exactly, but many patients complain of muscle pain. So if the patient develops acute heart attack, usually in the first 1 month, we have, according to the guideline, we said that we have what is called high-intensity statin. What is the high-intensity statin? It is rosuvastatin and atorvastatin. And the dose of the high intensity for rosuvastatin is 20 to 40, and the atorvastatin is 40 to 80. The problem is, everybody said in the first 1 month from the heart attack, usually you can go to 40 rosuva or 80 atorva. And then after that, you have the chance to reduce from 80 to 40 and from 40 to 20. If the LDL is not within the target which you wanted for somebody who developed heart attack, which either 70 or 55, depending on how his risk, it is high risk or very high risk, you have to add isotrol 10 milligram, and you expected the reduction will be about 18%. If the patient does not able to fulfill this criteria, which means after you start statin, high intensity statin, added isotrol on top, and the patient is not able to reach the target, here the place for the PCSK9. Or if the patient is not able to tolerate the statin because of the muscle pain.
Excellent. Great. Thanks, Dr. Sharif. Shortly, we'll go to cases, STEMI cases, and so stay tuned with me. And there's also a question that I received in relation to the STEMI.
But I want to add, Zubaidi, the STEMI cases would mean that the patient now develop the heart attack. So, but we are, as a physician, our aim to prevent him from developing the heart attack.
Exactly. Prevention is our objective.
And despite this is STEMI presentation, but we now understand why we introduce the primary and second prevention.
Exactly. Yeah, that's the reason. I mean, we're focusing. We want to focus on treating these patients, but at the same time, we want to make sure that prevention. You don't forget about the prevention.
And also another important, Zubaidi, just to interrupt you, that we have to know that within 5 years after the patient develop heart attack, 45% of them will develop another heart attack. And we have to know that this is very high percent. So we have to do that secondary prevention with very aggressive.
Okay, great. Thanks, Dr. Sharif. Thank you. Okay, so we are back again, and now I'm going to share with you some of the cases. And please, this is more of an interactive. So, please, feel free to share your questions and participate, in answering the questions. So the first case is basically a 44-year-old male who is known to have a history of hypertension and diabetes. He presents with chest pain, sweating, and shortness of breath. He doesn't have any past medical history. This is kind of typical case for a STEMI in Abu Dhabi. I know some countries, they see older patients, but a lot of our patients are in their 40s, 50s. So this patient comes in with chest pain. So one of the key messages that I want to share with you is chest pain. It doesn't mean only chest. I don't know if you can see my mouse here, but it doesn't mean only chest. So the patient can present with a chest pain, but also we see patients who present with neck pain, with jaw pain, with shoulder pain, epigastric pain, or arm pain. So it can be together, and it can be, one of these areas. So any patient who presents with pain from the jaw down to almost to the umbilicus, you have to think about ischemia, or you have to think about myocardial MI or myocardial infarction. Now, it has to be, of course, the right clinical scenario. So a middle-aged man with the risk factors, usually put it in your mind, does this patient need an ECG or not? So this patient is got the right profile, the demographic profile, middle age, diabetes, and chest pain. So what is expected is to get an ECG on this patient. So we did the ECG, and this is the tracing, the 12-lead ECG. You got lead 1, 2, 3, and all the chest leads and the limb leads. So what is there? Of course, in the usual sessions, usually we interact, but in this format, I'm just going to demonstrate or show you the abnormality. I'm sure most of you will get it. So there is an ST elevation involving lead 2, 3, and AVF. As you can see here, this is the isoelectric line. And then the STs are sky high, they're about more than 7-8 millimeter above the isoelectric line. This is an inferior ST elevation myocardial infarction. This patient also got an ST depression involving lead V2, and this may indicate that this patient also got a posterior infarction. To know if there is a posterior involvement, you can ask your ECG technologist to record for you a posterior leads. So here we see leads down to V6, but you can get up to V7, 8, and 9, which is the posterior leads, and you can demonstrate if this MI is an extensive inferior posterior. But obviously, clearly, this is an ST elevation myocardial infarction. So what do you do? So you can answer the question. You had my first presentation where I talked to you about, the strategies. So what do you do? This patient got, we're suspecting, or we're almost confident that he got acute myocardial infarction on the ECG. So would you get an troponin? Would you order an echo? Would you send this patient for a primary PCI, or would you give him a thrombolytic therapy? So I'm just going to get you some time to answer those questions, and please go ahead, hit the number, and let's see what you have. So still, I'm waiting for the answers from the team. Maybe, yeah. That's okay. Sure. So maybe, yeah. So I don't know if there's a disconnect in the questions, but of course, this patient, obviously, he should go for a primary PCI, so it's very clear ST elevation on the ECG, and he should have a primary PCI. Troponin elevation or troponin testing is not indicated in ST elevation as a diagnostic tool. So if you have a clear-cut history and obvious ECG, then the next step would be reperfusion therapy, either a primary PCI or thrombolytic if the service is not available. But echo, if the MI is still under question by the ECG, and troponin is more of a prognostic. So if we're expecting the troponin to be very high, so the level of troponin elevation is not important in the diagnosis. So this patient should go ahead and get a primary PCI. One key thing, you have to familiarize yourself and make sure that you know is the criteria to diagnose ST elevation myocardial infarction. So there is a published criteria by the guidelines, and that states that patients who got ST elevation of more than 2 millimeter in V2, V3, or more than 1 millimeter in 2 limb leads, then that is a diagnostic of ST elevation MI. Of course, some may change this criteria depending on the age and the gender. So younger patient, they will ask for more numbers, like 2.5 millimeter, because there's more common early repolarization. Also 1.5 in female in the chest leads. So age and gender sometimes may give a different sensitivity and specificity in terms of diagnosis, but definitely any patient with a 2 millimeter ST elevation or more than 1 millimeter in limb leads, you have to strongly consider ST elevation MI, and you have to treat that patient accordingly. Of course, clinical picture is very, very important. You know, a patient with ST elevation and no symptoms, patient who comes to your clinic and suddenly you find he got ST elevation is different than someone who comes with chest pain and someone comes with what suggests like a pericarditis and so on. But you have to treat the patient as an acute MI till proven otherwise. The other diagnostic criteria is left bundle branch block. The ECG that shows a left bundle branch block, you should be treated as ST elevation myocardial infarction. Another important point is patient who comes in with the chest pain and got the background profile of ischemia, like someone middle like this patient, you know, he got a risk factor and he got a chest pain. Then, or as I said, any pain that comes up from the jaw down to the umbilicus, strongly consider the ECG, and the ECG should be done within 10 minutes from the patient's arrival. And then another important thing is when you record the ECG, you have to read it. So if you order an ECG, you have to read it as fast as possible. So once the ECG gets out of the machine, it has to be looked at carefully. If there is an ST elevation, then the management starts there. So the other point is, if the patient is diagnosed with ST elevation MI, the next step is to connect him to a monitor, because these patients are at high risk of getting arrhythmias, malignant arrhythmias like ventricular tachycardia or ventricular fibrillation, where they can get treated for. So ECG within 10 minutes, get it read, and also ECG within, and then connect the patient to a monitor. So those messages are very, very important, you know. The next case is a 64 years old male with epigastric pain, sweating. Now he presents to a hospital where there's no PCI, and he needs 30 minutes to reach to a PCI capable hospital. He got diabetes and he's a smoker, and that's his ECG. So the ECG demonstrates ST elevation in lead 2 and lead 3 and lead AVF, more than 2 millimeter, clearly. He got also a dominant R waves involving lead V2, and the chest leads may indicate also in posterior infarction. There's some ST depression there also. So the patient got the background history, the clinical picture of suggestive of ischemic presentation, of myocardial infarction presentation. The ECG was done appropriately, and it does show ST elevation in the inferior and maybe some posterior involvement. So what is the next step for this patient? What would you do? So thrombolize this patient, transfer him to a PCI capable hospital. Remember, this patient presented to a hospital where there's no cath lab. So should you transfer him to a PCI capable hospital? Should you admit him and start him on aspirin and ticagrelor? Should you obtain an echocardiogram? So waiting for your answers. We should not take long on this, so we can move forward with it. I'll give you a few seconds more. Okay? Yeah. So exactly. So I'm just trying to see the percentage of it. So excellent. So 73% of you, 68% almost 70% say transfer to a PCI capable hospital, while 20% thought of thrombolysis. Of course, there's few people who thought you should admit and start on aspirin ticagrelor. So let me go over those answers. So admit and start aspirin ticagrelor. Of course, you do that, but the key, remember, with the STEMI, your objective is to restore flow and open the artery. So opening the artery is a priority. So here the questions are not, is what's your first step is to arrange for a transfer to a PCI capable hospital. And you have to make sure that these arrangements, of course, when you practice in a hospital, there is no PCI, and you know that you can deal with the STEMI patients that comes to you, you have to have an arrangement to transfer your patients. So think of it as, if I am going to face a STEMI, and then in my practice, how am I going to deal with it? So when you answer, so to answer that question is you say, you have to go and get an arrangement with a hospital that has a PCI and tell them, if I get a STEMI, I'm going to transfer that patient. So when you get that case, you are ready to transfer him and they are ready to accept him. So definitely it's not the time to discuss transfers when you don't have agreement. So what we're trying to say is the best practice is to transfer this patient to a PCI capable hospital. Your transfer process should be very clear, very outlined. The protocol of transfer should be there, and this patient, ideally, he should be transferred to a PCI capable hospital. Thrombolysis is an option, but it's a suboptimal option. Of course, these patients needs to be on aspirin ticagrelor. But if I am to choose between the four options, definitely transferring to a PCI capable hospital would be my first choice. And as I can see here, the majority of people pick that choice. So the obtaining an echocardiogram in this patient is something you need, but it's not the first thing I would do. Of course, I need an echocardiogram during the hospital stay before I discharge this patient to know the LV function, and also if there's any other mechanical complication from MI. Of course, we talked about the importance of PCI, evidence PCI compared to thrombolytic. I showed you in the presentation earlier, and I showed you the risk of bleeding. This patient is above 60, and his risk of intracranial bleed is relatively high. Third case, we have a 69 male diabetic smoker. Okay, and he presents with chest pain. He presents to the your emergency department as a walk-in. That's his ECG. I don't know. I wish I have people in front of me so I can interact with and ask them, what does this ECG show? But I hope the majority of you can get it. So two things here. One is the MI. The second is the arrhythmia. So the myocardial infarction here is inferior ST elevation, obviously in lead 2, lead 3, and lead AVF. And then, of course, there's a severe bradycardia, and it looks like there's a sinus arrest in this patient. So what would you do for this patient? I'm going to get you a few seconds to decide which one do you want to go with. So you have the answer, the questions in front of you. Please go ahead and answer. Okay. I think there's. Do you have the question on, because I can't see the screen, so I don't know if you have the right question or the right, order of questions. Okay. So I guess I don't have the right order of questions, but what I will do is I will go over those answers. So transfer. So 75% of the people answered to transfer to a PCI capable hospital, admit with aspirin, ticagrelor, and TPA. So again, the message we can go backward to the question. So 69, diabetic, smoker, chest pain, very clear-cut ST elevation, and the hemodynamic instability. So there is so this is STEMI with the hemodynamic instability. So this patient is a very high risk of mortality because he's developing an arrhythmia. So even thrombolytic becomes less of an option compared to getting him to a PCI. So this patient presents to a PCI hospital, but even if he presents to a non-PCI hospital, I would still push hard to get him to be transferred to a PCI hospital. Of course, I will give him the aspirin and ticagrelor, but transferring to a PCI hospital is the key. I would not thrombolize him at all if I have the option of a nearby PCI center. So these patients, time is muscle. This patient got a very large myocardial infarction, inferior and posterior, also the same as the last case. And they, as you can see here in this slide, of course, the evidence around time is muscle, and treating this patient early makes a huge difference, massive difference in mortality. Basically, you're reducing your patient's mortality, from 20%, or if you look at the trials of the thrombolytic therapy and the control arm, if you consider this patient not getting any reperfusion, his mortality is very high, somewhere in the 20%, and compared to somewhere down 5% maybe if he's well treated, transferred in a timely fashion. Time is muscle again. The earlier you treat your patient, the 1 year mortality is very low, 2%, maybe 4%, as compared to somewhere in the 10% at 1 year if they get delayed. This is all comers, not a complicated patient like ours. Our patient here is a very high risk to start with. So even if you get him the best treatment, maybe his mortality is somewhere in the 10%. If you don't treat him, of course, his mortality is extremely high. Time dependency, as I said, is well established. Remember, when you're dealing with STEMI patients, time is muscle. Case 4. So demographics. So this is a 42 male. He doesn't have a risk factor. So remember, middle-aged man is enough risk or enough reason to make you think of any pain between the jaw down to the umbilicus to think about ischemic heart disease. So 40 male is as I say, is enough to make you alerted that this patient may have an ischemic pain. So this patient definitely he will require an ECG. He got a chest pain. He's a male. He's a 42, and he presents to a hospital that is 30 minutes drive from a PCI capable hospital. So in Abu Dhabi, there is a lot of small hospitals that we have, and they do have emergency departments. They deal with acute cases, and such a patient can present to any of those hospitals. So what do you do for such a patient? You get an ECG. So that's his ECG, and I hope most of you will get it. So what he got is ST elevation in V2. As you can see here, this is your isoelectric line. There's ST elevation. The same thing in lead V3. So ST elevation, something between 3 to 4 millimeter in these leads. Also on the lateral leads, which is lead 1 and AVL. A lot of time we forget about these leads, but remember that there is a significant ST elevation of at least 2 millimeter there. There's ST depression in the inferior lead. So a lot of leads are involved either by ST elevation and ST depression. This is usually is a risk identifier. So this tells you a lot of ECG shifting is an indication of a higher risk patient. So this patient is a very high risk. So that means that you need to act fast and you need to treat him fast. This patient, as you can see in the slide, he was treated within 82 minutes. So as a system, if you have a well-established, so this hospital got an agreement. I know that the guys are in this hospital, they have an agreement with our hospital to transfer the patient. So when they diagnosed the patient with the STEMI, the patient was transferred within a timely fashion, and he was directly taken to the cath lab where he had his artery opened within 82 minutes from the door of the referring hospital. So usually when we monitor the door to balloon time, we monitor it from the door of the receiving hospital to from the referring hospital to the receiving hospital. So this patient was treated within 82 minutes, as you can see. So obviously, I answered that question. So the patient was transferred to a PCI capable hospital. I hope all of you will get there. So if you are to pick the answers, please go ahead. I'm not going to spend a lot of time here, but show me. Here I can tell who's listening and who's not. So, So show us the results. Control room. Yeah. Okay, excellent. I told them, I already shared the answers. I hope everyone got that answer. Excellent. So this answer tells me 90% of the attendees are listening, because I got the answer kind of indirectly before in the previous slide. So, so transferring the patient again. Now I'm going to, re-emphasize on the message for hospitals that does not have a PCI center or no cath lab. What you need to do is you need to have an agreement with the hospital that has a cath lab to treat your patients who comes with a STEMI. Why? Because primary PCI is the standard treatment, the best treatment by all guidelines. A clear STEMI activation plan. So you have to have that activation plan. Your transport, your ambulance, you know which ambulance is going to take the patient. You know what are you going to give the patient in terms of treatment and antiplatelet, anticoagulant, monitoring, all of those, who's going to accompany the patient. All of those questions has to be addressed before you have a case of a STEMI. So that's a STEMI activation plan. The agreement to the other hospital, the transfer protocol. How is the patient going to be transferred? As I said, it has to be clear to all the emergency department staff. It should not be only with the chair or with one or two of the staff. It has to be routinely re-emphasized, and the staff has to be educated regularly. This is how we handle a STEMI. If we get a STEMI, this is the way we're going to do. We're going to transfer him to this hospital. This is the team who's going to transfer him. This is the medication he should receive, and so on and so forth. Those has to be clear. You have to measure something called door in and door out. So the patient, when he gets into your hospital and getting out, that time is considered now a quality indicator in a lot of healthcare system. So it's a door time, door in, door out time. Remember to monitor it. If you are a non-PCI hospital, this is a very important quality indicator that has to be monitored and watched carefully, because that will indicate how good you are doing to your patients. Usually, most of the guidelines recommend something between 30 minutes to 40 minutes for hospitals that does not have a PCI capability to get this patient, to diagnose them and to transfer them out. So you need to get this patient within 30 minutes out of your hospital to a PCI hospital where he can be treated within a timely fashion. So that's great. So we'll go to case 5. So case 5 is a 56 years old female, hypertension, smoker. Also, she got a strong family history. So those risk factors are enough to be qualified for an ECG and rapid attention. So she comes to with a chest pain, but now to a non-PCI hospital. And it's very far, 4 hours to reach a PCI capable hospital. So remember this factor, okay? So female, with multiple risk factors, chest pain, and she comes to a hospital. So the scenario here is not a 30 minutes like the previous scenario. No, here it's a 4 hours to reach a PCI capable hospital. Very bad ECG. Again, I wish people are here to answer that or to read it for us. Do your best to read it and get the diagnosis. As you can see here, those striking changes in the anterior leads, V1, V2, V3, V4, there's a hyperacute T's and there's ST elevations. And also there's some inferior, maybe this indicates a wraparound LAD. The LAD maybe is supplying also part of the inferior wall. And also we have some ST depression involving the lateral leads. So very bad ECG, a lot of STs, hyperacute T's, indicating that this is a very acute ST elevation MI involving the anterior lead and maybe some inferior changes. Now we'll go to the question: how would you treat this patient? Would you treat her with TPA, again admit aspirin, or transfer to a PCI capable hospital, or order an echo? So let's get those on the screen. In order, please, control room. Okay. Few seconds. We don't want to spend a lot of time here, so we can go over more cases. Okay. I'm waiting for the answers here. So still refreshing. Okay, excellent. So I got the results here, and not so of a surprise. So maybe maybe my questions are a bit confusing to some of the audience, but that's okay. It's not a problem, and the intention is to trigger the discussion. So the majority of 60% of the people or the attendees, the audience, picked administer TPA, and I think that's the right option, because to send this patient to a PCI hospital is going to take more than 120 minutes. Which is, this is a 4-hour transfer. So you need to give a thrombolysis. So if you are to estimate that your patient is going to be treated more than 2 hours with PCI, then thrombolysis becomes a better option. I hope that's very clear. So PCI, as I stated it early, is the best option, or the option of, or the first choice, if it can be done in the proper setting with an experienced team in a timely fashion. And that timely fashion is within 120 minutes from the time the patient presents to you. So if the patient presents to your hospital where you don't have a cath lab, and you think that the transfer and the treatment is going to be more than 120 minutes, then thrombolysis becomes a better option. And this is a typical case. So this patient transfer is going to take more than 2 hours, or the whole treatment is going to be more than 2 hours. So the best option, as the majority answered, is TPA. Of course, this patient will receive, as I said, maybe there's some confusion. Definitely, this patient will need aspirin. Ticagrelor is the first choice. But remember, treatment of STEMI, reperfusion. You need to open that artery. And there's 2 ways only to open the artery: thrombolysis or PCI. Thrombolysis or PCI. You have to pick one of those. And of course, aspirin and ticagrelor is a standard of standard treatment, or aspirin and antiplatelet therapy is a standard treatment for these patients. regardless if they go for thrombolytic or they go with PCI. They need to have dual antiplatelet therapy. So this patient received the TPA, and then she received the TPA, and then she was transferred. And this is a STREAM trial, which included almost 2,000 patients who are unable to undergo primary PCI within an hour. So this is a high-risk patients, and also, the time is short that the investigator picked. And patients were randomly assigned to undergo either primary PCI or thrombolytic therapy. Angiography was performed within 6 to 12 hours after randomization. And of course, the difference was not statistically significant. So if you think your patient is going to take long to be transferred to a PCI, then thrombolytic is an option. Long means the patient is going to take more than 120 minutes to be treated. So fibrinolysis is still an option if the patient is going to take long to be transferred. Let's move to, so we have only another few minutes. I think we can go over this case, which is a 39 years old male. Same thing, hypertension, smoker with premature family history. And he got a chest pain, sweating. He was thrombolized and he was transferred. So he was thrombolized in one of the hospitals and transferred to us. So when he arrives, so the message here is, I'm trying to send is, if you have a patient who was thrombolized, either at your site or you transferred him, you have to reassess if the thrombolytic therapy worked or it did not work. Remember, thrombolytic will open only 55 to 60% of the arteries of those patients. So the patency or the patency rate or the chance of that thrombolytic therapy opening the artery is not as high as you would expect. Only 55 to 60% of the patients, they will have their arteries open. So how can I tell if this patient, if the thrombolytic therapy worked or it did not work? So number one is you assess the patient. Does the patient have ongoing chest pain? If the thrombolytic therapy worked and it opened the artery, usually the chest pain starts to resolve. If the patient continued to have chest pain after an hour or 2 hours of giving thrombolytic therapy, then the thrombolytic did not work, or there's a good chance the thrombolytic did not work. The other thing is you repeat the ECG. If the ECG shows ST elevation or persistent ST elevation, then that's another indicator that thrombolytic therapy did not work. The other factors, of course, is the hemodynamic instability. If the patient is continuously getting arrhythmias or getting a hemodynamic instability in terms of blood pressure, like cardiogenic shock, all of those are an indicators that the patient is not reperfused. And those are signs that the patient should be, that thrombolytic therapy did not work. So such a patient, what would you do? Would you repeat thrombolysis, or would you get him to a cath lab, or would you get an echo, or again, the aspirin ticagrelor? Definitely aspirin ticagrelor should have been given, so don't pick it, please. Waiting for the answers. This is our last case. So I hope most of you get it correct. Control room, give us the answers. Activate the cath lab. Excellent. So almost 90% got it. So 90% thought of activating the cath lab. Repeating thrombolysis is, I would say, is not an option. If it didn't work the first time, the next time you're just going to you're increasing your bleeding risk without adding without gaining any benefit. So I would not repeat thrombolysis. I would activate the cath lab and get that occluded artery that did not respond to the first dose of the first thrombolytic, get that actually opened by angioplasty. Of course, the patient, I would assume, received already the aspirin and the antiplatelet therapy, and of course, he will need an echocardiogram at a later stage during his hospital stay to understand the LV function. Of course, such patients' LV systolic function is going to be impaired. So emergency angiography, this is from the guideline, from the European Society of Guidelines, few messages. Emergency angiography and a PCI, if indicated, is recommended in patients with heart failure and shock. Rescue PCI is indicated. So this patient PCI, we call it rescue. Rescue because we are rescuing the patient after failed thrombolytic. So indicated immediately when fibrinolysis has failed. So how do we tell that fibrinolysis failed? Less than 50% ST segment resolution at 60 to 90 minutes. So if you repeat your ECG within 60 to 90 minutes and the ST did not get down to less than 50% of the, so if there is a 5 millimeter ST elevation, I would expect the STs to be less than 2 millimeter, for example. Or at any time in the presence of hemodynamic instability, so blood pressure is low, or electrical instability, like the patient gets a recurrent VT or a VF, or worsening ischemia in the form of course, chest pain and ST changes. So those are the key messages for rescue PCI. And of course, there's multiple trials like REACT that looked at such a scenario with an evidence of a benefit of rescue PCI compared to conservative treatment or repeat thrombolysis. So if you elected to repeat thrombolysis, the patient's chance of survival is less compared to getting the patient for a rescue PCI. So this is the message out of that trial. Of course, I would like to answer questions. I know there's multiple questions that we received. I'm just going to answer a question that came to me before I close. And that question talks about policies. And I think, when we talk about STEMI care, we talked about the clinical side, but more important is the network, the relationship between hospitals and between providers. Either it's a hospital to hospital or it's emergency physicians, cardiologists, intervention cardiologists, nursing, EMS, pre-hospital care. All of these people has to come together to ensure that the patient is getting the best treatment, because all those people are involved, all these different specialties is involved in the care of STEMI. And I am sure if we have Paul here to look at how many of the attendees comes from these different specialties, I'm sure we'll have a different representation. So all of us plays a key role in managing STEMI, and all of us has to be familiar with identifying these patients and familiar as to how to triage this patient to the right facility and right place to be treatment. So the question says, will you be able to enforce policy to transfer patients to hospitals where there is a cath lab? Of course, this is something important. So you see some hospital says, I don't have a bed for the patient. This is not the time to discuss. STEMI care bed availability should not be part of it. Accepting transfers should be mandated, I think, by the regulators, by the regulator who governs the policies, the healthcare policies in any community. So if you are having a cath lab, you should have a hospital where that provides a 24/7, and those hospitals has to ensure that they staff their cath lab with the right people and also the right equipment. And also we should work on enforcing this care. Of course, in our here I'm talking about our healthcare system in Abu Dhabi. Luckily, we have a lot of hospitals that provides a 24/7 service. They're well staffed, they're well equipped, and they're supported by the government to take care of these patients. So enforcing it, I think, is very easy. And even without enforcing, it needs the will of the providers to send these patients to the right hospitals, and they can find those hospitals easily. Either it's SKMC, it's SSMC, or it's Cleveland Clinic, or it's some of the private hospitals within Abu Dhabi that provides this 24/7 service. So I'm not going to do more cases, I think, because we're running out of time. I would like to thank you all for participating in this symposia. I would appreciate your feedback as to how to get it delivered better in the future. We usually repeat it every quarter. I think we can do it even more often than that, even on a monthly basis or every 2 months, to ensure that we're spreading the message of educating people with our healthcare providers, because all of them, as I said, participate in the care of STEMI. So we need to educate each other. We need to share with you our experience, but also we need you to share with us your experience. If you faced a STEMI case, how was it managed? Was there a delay in the care that you think should not have happened? And share with us that, so we can work with the different parties, either it's a hospitals or it's a regulator, to ensure that we address those barriers so the next patient will be treated appropriately. Your interaction and your participation is appreciated. And I would like, before I close, to thank my colleagues in organizing this event. Of course, all the people that I mentioned at the start have been very instrumental in terms of preparing the cases, preparing the presentation, and also I'd like to thank Amgen for their support to get this event out there. So great, and see you again, and enjoy your night.